Hello, I'm Jacques Cohen. We are here in Amsterdam on a lovely grey day. It's not raining. And we are at the COGI meeting. And we just finished a very, very interesting quality control QC/QM session in the embryology session of this meeting this morning. And I have with me Laura Rienzi, who gave 2 terrific talks. And with a lot of response from the audience. And so what I like to do is go give us the highlights. So the first talk was on how to improve the quality in IVF lab. You said a lot of very good things. Give us a highlight.
So embryo culture is really a very important part of our job, and the success rate is really strongly related to the quality of the culture. So I think it was a very important topic to discuss here with colleagues. And we know that we cannot really improve the quality of the embryo that we generate in our laboratory, but we can make many things that potentially can affect the quality.
Yeah.
So my talk was really taking under consideration the most important factors that can reduce the quality of our embryos during manipulation and culture, right. And that we should minimize stress, yep. And how much the embryo is able to react to stress and to compensate to stress. And so I think that standardization of the culture is necessary to ensure the quality everywhere.
Yeah. So one thing that was striking for me is you demonstrated with a recent example in the literature, a 2016 paper from the Maastricht group, and I'm sorry, I just forgot the first author's last name, but it's the Dumoulin team, comparing one medium that is a sequential system that has been improved over the years, the G5 system, with an old medium based on the back to nature philosophy called HDF, which has created a lot of babies, but a long time ago. And so those are kind of 2 extreme systems. And what is striking to me is that the clinical findings were very different from your conclusions.
Yeah.
And so can you explain that?
Yeah, I think that, so when we look to randomized control trials, the high level of evidence is only related to the primary outcome measure.
Right.
Because secondary outcome measure, as in this case, may be affected by different distribution of patients.
Right.
So in this case, because the number of women having a live birth was different in the 2 groups, and
right.
then there was also a different distribution in singleton and twins, yeah. The quality of the evidence related to obstetrical outcomes was, for me, very, very low and
yeah.
underpowered.
Yeah.
So I don't think we can conclude with that study about obstetrical outcomes, yeah. But it is, of course, interesting to see that a culture system from the beginning of life can have a long-term effect on, yeah. on the live
yeah.
births.
Yeah, and I mean, there are so many confounders in all of the studies we do. There's not much we can do about it. And so certainly in this case, sample size becomes important, because often you get subgroups, you have no choice in your analysis. And so evaluations become very, very complicated, and conclusions even more complicated. So I think that was a very good message. Also, it shows that you can't just read a paper by looking over an abstract. You really have to read the paper. And so because you could come to conclusions that one medium is better than the other, and it's not that simple. So I think that was beautifully demonstrated. And your second talk follows the same critical line, and was to me a major event here this morning, because in the second talk you go into the importance of selecting a sperm during ICSI, and particularly emphasize the IMSI work. What are your conclusions about IMSI and selecting spermatozoa based on morphological criteria?
Okay, my conclusion about sperm selection is that to date we don't have any validated technology that can improve sperm selection prior to ICSI. more than what was reported in 1992 from the first paper published by Giampiero Palermo on Lancet, that we need a normal appearing motile sperm. This is evident. We have a lot of evidence that motility, even very small motility, and normal appearance is necessary, because abnormal, when you cannot find a normal appearing sperm in the ejaculate, which reflect also the quality of the spermatogenesis itself, not only the quality of the sperm. This may affect fertilization rate, and this was reported by a group of Brussels in 1992. But other than this, after 15 years, we don't have clear evidence, level 1 evidence in the literature, that any technology is helping to improve implantation rate of a deriving embryo and the live birth rate. So the take-home message that I want to give is that an embryo, it's a big puzzle. And there are many pieces of the puzzle that has a different weight. And we know that female age and chromosomal abnormality is a big piece of the puzzle. And female age is the most predictive characteristic of the embryo. But the sperm probably is a small piece. I don't know how much small, but it's a small piece. This is why it's very difficult to find evidence by changing the sperm. We change the completely picture of the embryo. So morphology for sperm, but it's true also for oocyte and embryo, is fully predictive of the intrinsic quality of the cell.
I think you also very rightly pointed out that the emphasis really has not been just on morphology, but on what we call vacuoles, which you pointed out are vacuole-like. So maybe you can describe, because I think this is important, and your pictures are very convincing. It's important to describe what are these structures.
This is nearly funny, no? But in the literature, for 15 years we were calling structure, but it is in fact not the real term. So I just took picture from the studies. It's not even my own picture. So studies that are describing nuclear vacuoles in the sperm, in fact, if you just look, you don't even need to read the paper, but just look to the picture, you see that this kind of structure are mainly related to the acrosomal region. And there are some studies with different microscopy approaches showing that it is invagination of the membrane. So my key message here was, first we have to understand what we are looking. First we have to have a strong biological background behind the technology, and then start the clinical application. So I don't know if the invagination of a membrane is reflecting quality of the sperm. I'm not saying that it's not,
so it's
or
possible,
it is. It's possible, but it's not a vacuum. It's not
a
full of
vacuum.
it, and
it is important. There's little to no cytoplasm in the spermatozoa, and the little bit there is in the midpiece. So I do think that midpieces are underestimated. I think particularly the centriole, the quality of the centriole, which we may not be able to judge based on morphology because it's so tiny and elusive, that probably has an effect on some forms of mosaicism. These recurrent high levels of chaotic mosaicism that you see in an occasional patient, and then doing a parallel insemination with donor sperm. I mean, there have been some case reports that show that there can be differences there. So I do think there is a contribution, but it's very poorly understood.
So we know that the meiotic contribution of aneuploidy of a sperm is low. We don't really know the mechanism related to mitotic aneuploidies, those that generate mosaicism, but we know that the impact is quite low in human embryos that reach blastocyst stage. We just have published a paper about the real impact of mosaicism on embryo, and I'm sure it's a combination of more than one factor also in this case, not only the oocyte, the repairing capacity of the oocyte. It can happen also at 2-cell stage, 4-cell stage. I don't know how much it's still of sperm origin, but it's probably, nature is very complicated. And it's probably a combination of many, many different factors.
And the frequency has always been high, even in the very poor methods 15, 20 years ago. Always published, all the publications showed a high frequency of mosaicism. It's just now recently that it becomes more worrying because of this increased resolution that we have.
It depends also on the stage of development where your seismosis is, because there is a self-selection when you get to blastocysts, very probably.
Absolutely, yes. So, I think in conclusion, your talks clearly indicate that there is so much more when you look over the literature, that part of our duty as embryology scientists is to read the literature and do this not in a superficial manner. I mean, you showed that very clearly in your talks. There's a lot behind it. You know, authors have to publish an abstract. They have to get a capsule message out, but it's very hard to do. And so you're missing major points sometimes as an author. You want to present it, but you know, you submit the paper and you get the cutoff, right? You're 40 words or you're 120 words or 300 words over, and you have to cut it down to what the electronic system tells you to do. And so it's important to look at papers at a minimum with tables and figures and maybe read the discussion.
And share the results
And
during
share the
meetings
results during the
and
meetings.
discuss like we are doing today.
Right.
Today,
that's right,
I think it's
yes.
really very important because
Right.
only
Well, very
this-
good talking to you.
Thank you.
Yeah, pleasure.